Good afternoon, everyone. I want to thank you for attending this month's lecture. It will be on interventional oncology and presented by Dr. David Isaacs.
Okay, great. Thanks for having me. At the end, I'm going to have a couple case examples. Are people going to be able to type in, answers to questions? That should be okay, right?
Yes.
Okay, perfect. All right. Well, thank you guys for having me. First time doing a webinar here, so. Anyway, I wanted to talk to you guys about something that's very exciting, I think, in the world of radiology, the world of medicine, the world of oncology in general, which is this field of interventional oncology, which is overall just a subset of interventional radiology. So, like I said, it's a hot topic. There's books being printed on this, and there's plenty of articles that are going out in the literature about different ways of treating tumors, different modalities, different devices. So if there's anything hot in the world of radiology, it's probably this whole field, I think, of interventional oncology. All the big meetings are being now having symposiums on the interventional oncology component. So it's a very exciting field to be in at the moment. So in general, what is interventional oncology? What is it that we do? What is it we look for? What kind of patients do we set up? So we're going to go through a little bit about the field itself. We'll go through some of the tools. We'll also talk about the literature, because it's very important to realize when you do interventional oncology, you're not just a radiologist anymore. You're treating patients, and in addition, you're not just treating patients, you have to analyze the literature that's out there. As a typical radiology resident, you basically will go through lists of differential diagnoses. You're going to have tons of them, from brain masses to kidney lesions to pulled muscles or whatever the case may be. But it's not just learning differentials anymore. It's really learning about how to analyze the literature and figure out what is the best treatment plan for your patient that you're encountering. Then we go through the weapons that we use. We're going to have kind of a military mindset today since it's Veterans Day, but an interventional radiologist is basically a warrior that's trying to defeat cancer on some level, or to put it at bay as best we can. And we'll go through some cases at the end, and we'll look at some success stories. So in general, treating cancer uses 4 different components. There's the medical oncologist, there's the surgical oncologist, there's the radiation oncologist, and then there's the interventional radiologist. And pictured here is your typical interventional radiologist when they walk out of their fellowship program. So we're ready to go. We have all of our tools. We're ready to do battle as best we can with the cancers that we're going to be facing. So again, we'll first start off with knowing your enemy. You have to know how to analyze the literature. Again, it's not lists of differentials anymore. So some of the things that we have to look for in the literature are the phases that we go through, some of the cancer treatment trials and the phases. So in general, we're looking at the studies. A randomized control trial is the best type of study that you could use. You basically use comparable groups by eliminating selection and biases in those type of studies, and you have a balance between the control and the intervention group. When you look at the individual sides of people that got nothing and people that got treated, you can do a comparison between the two. And blinding is also important, so that the operator themselves don't know exactly what they're doing to treat the particular patient. So that would be the best way to treat patients. So in addition, as a radiologist, which many of you guys are just going to be, diagnostic radiologists, you have to know how to report the findings that you see. How do we grade, how do we characterize the lesions that have been treated, and what kind of response can we say was a good response, bad response? So there's different ways to evaluate these lesions. You can have a complete response, you could have a partial response. Partial response being about 50% decrease in the sum of the disease. Disease progression refers to a greater than 25% increase in the size of a tumor. or the appearance of new disease. And stable disease is basically a lack of response or disease progression. So there's different criteria that's out there. One of them is the RECIST criteria that's utilized. And some focus on the target, some focus on non-target lesions, some focus on lymph nodes, but overall, you kind of have to globalize the treatment that you've done on that particular patient. So other good terms to know when you're analyzing the literature is overall survival. That's the gold standard endpoint for cancer research. You know, how do people do? Do they live? Do they make it through this event? Are they cured? Are they not cured? You know, another thing is time to regression. You know, how's the time from the randomization to the time of the disease progression? You know, how long do you keep it at bay? How long do you prevent tumors from spreading? You know, do you keep it at bay for years? Do you keep it for weeks, for months? You know, how do they do? And progression-free survival, which is the time from the randomization up to the time of the objective disease progression to overall death. You know, how long does the patient stay well during that particular time? So all these things are crucial to analyzing the literature that we have. So I know this is a busy slide, but it basically gives you a list of a bunch of different criteria that people might use in order to evaluate tumors and before treatment, after treatment. So what I like to use in general is the modified RECIST criteria. And this shows a complete response, which is where you have disappearance of the tumor. You could have a partial response, stable disease, and then progressive disease. So utilizing this kind of chart, you can analyze how well you've done with treating a particular tumor. And then you can characterize it, and then you can, you know, have your own little, you know, trials in your own hospital. So again, when analyzing the literature, and in general, when treating a patient, there's different levels of evidence and strength for the recommendation as to what is the best modality or treatment for that particular patient. Level 1 is going to give you the best. It's got the best randomized controlled trials. Level 2, as you can see, is non-randomized, and then level 3 are going to be case studies, cohorts, you know, anecdotal trials when treating a particular patient and tumor. So, and then you have some additional guidelines from the Cancer Institutes where you have Category 1, which is a high level of evidence and it's appropriate to treat the patient utilizing a certain modality. You can have Category 2A and then 2B, which is lower and has less of a consensus as to is this the best thing to treat that patient. And then Category 3 is a kind of a crapshoot, you know, as to whether or not it's going to be good or not. So, so in general, when treating the tumor, chemotherapy is the first line agent. It's the best option many times to cure a particular disease. Again, it depends on the type of tumor that you're trying to basically kill. Lymphoma, you know, at this point, we're not really treating anything like lymphoma. But again, chemotherapy is the best way to do it. So second line would be if the patient doesn't tolerate the chemotherapy or the initial treatment option. And then salvage is after none of the above work. You know, what are our last resort options? What's palliative? What do we have that could maybe keep this tumor at bay for the patient to survive a little bit longer? And many times the oncologist will come to us to say, hey, is there anything else you can do for this patient? You know, we're out of options. We've tried everything. There's been a change in the exact type of tumor. You know, so all those things play a role. So again, what are our weapons? What do we use to treat these particular tumors? So as a radiologist, interventional radiologist, the first tool that we have really is biopsy, because many times patients will come to you and they don't even have a diagnosis yet. Sometimes you can figure out what the tumor is going to be without having to do a biopsy. You know, if a patient comes in and they've got cirrhosis and they've got hepatitis C and there's a new liver mass, I mean, you could pretty much guarantee that it's going to be, you know, an HCC without having to do a biopsy on it. but sometimes just for documented purposes, definitely for insurance, sometimes you actually have to do the biopsy. So today we're not really going to talk about the biopsy itself, but a lot of, bread and butter, the interventional oncologist is going to be doing biopsies on a lot of different tumors. The next thing we use are ablation techniques to treat tumors, whether it's RFA, cryoablation, microwave. We'll talk about all these different type of modalities in a little more detail. And then we use embolization. Embolization is another local regional therapy is what they're calling it now, basically that, and you see a list here of different ways we can treat through bland or conventional chemo or some of the DC beads, and then radioembolization. So what are our percutaneous therapies? What do we use from the outside in, either using CT or ultrasounded therapy? You can have non-thermal, which doesn't use heat, which includes chemical ablation and irreversible electroporation, or you can use thermal techniques such as RF ablation and cryoablation and microwave, so for cooking tumors. So the first thing we'll go over briefly is chemical ablation. This is kind of an old school way of treating tumors. Even yesterday, talking to one of my senior colleagues, he used to treat tumors this way, but again, we really don't do this very often, directly at least, percutaneously. But you basically, with ethanol, it's inexpensive. You can use it on small tumors. Doesn't have the greatest 5-year survival time, 32, 38%. No heat sink effect, so it really doesn't matter what these lesions are adjacent to per se in terms of vessels. You just have to be very careful when injecting the lesions because ethanol can be very toxic to arteries and vessels and things along those lines. So it's a little bit limited in its predictability, and again, it's not really used very often, but it's more for historical purposes here. So one of the new things that's out there now is this thing called the nano knife, which is the irreversible electroporation. So in general, you have a tumor, and you're going to border the tumor by these probes, and you use ultrasound or CT, typically CT, to place your probes around the tumor, and it creates a kind of a electric field. There's an electric potential gradient that goes across the membranes in this particular area, and what it does is it causes holes to be made in the actual tumor itself and all the intervening tissue to cause a leakage of all the contents inside the cell, and that hopefully would kill the tumor. So it's not affected by a heat sink effect. Again, this isn't very common, but it is something that's definitely utilized in academic centers. It may gain more favorability in the future. So another basically bread and butter tool that the interventional oncologist is going to utilize is RFA. So RFA, radiofrequency ablation, has been around for a good 20 years or so now. And you're basically cooking, you're basically frying, you're heating up this tumor as much as you can to try and cause it to undergo necrosis. So it uses high frequency current, which causes an ionic water agitation and heat. And the goal is to, again, create coagulative necrosis in a margin around the tumor about 1/2 to 1 centimeter. And you cook it up to about 60 to 100 degrees Celsius. So here you can see basically a probe that's used now. This is one of the probes that I like to use. This is a box that we have in our hospital right now. That basically the tines on this probe correspond to this little circle here, and you get little temperature readings as to how hot things are. And once you get them to the desired temperature, then you cook for as long as you feel necessary, maybe 8, 10, 12, 15 minutes around that tumor, and basically cook it and do your best to try and get rid of it. So you try to avoid charring, things like that. Other probes out there now also have the ability to bend, which can be helpful because sometimes when you have a probe and a big patient, it can't really fit into the gantry of the CT scanner. So it's nice to be able to have some of these probes have more of like a flexible component to them. So, but in general, these are the RF probes that are utilized for treating cancers. Maybe about 5 to 7 centimeters would be the maximum you want to use to treat. So again, one thing you have to worry about are the vessels nearby. You don't want to be too close to larger vessels because that can suck some of the heat that's being given off by the probe and not give you the burn that's necessary in order to treat the tumor. So when evaluating a patient, you got to figure out, okay, what large structures are nearby? Are there any structures nearby? Sometimes you have to turn the actual handle of the probe itself to try to avoid a heat sink effect. Again, subcapsular tumors can be harder to treat because of location. It's best in general for tumors that are less than 3 centimeters in size, and overall it is a somewhat slow because you have to deal with heat sinks, and sometimes one tine isn't getting enough heat, so it can take a little bit of time in order to treat the tumor. So another modality that we use is microwave ablation. So this causes tissue heating by causing polar water molecules to realign, and basically you get heat and coagulative necrosis from the molecules moving back and forth at a very high rate. So one nice thing about it is that you can get a wider ablation zone. It's also faster. You can treat tumors in, let's say, 5 to 8 to 10 minutes once you get your probe in a good location. Sometimes it's nice because you can use multiple probes in order to treat tumors, and in general you get less of a heat sink effect. So this is becoming more popular as well to treat tumors. And lastly, we'll go through cryoablation. Cryoablation utilizes argon gas to basically freeze the tumor as much as possible. So you basically, this is a picture of some of the probes that are utilized, the size of the probes and the ice ball that they make. So you're basically freezing the tumor, and what happens is you freeze the inside of the cells of the tumor, then you thaw the tumor out again for about 5 minutes or so, and then you refreeze it, and that refreezing will cause cell apoptosis and transmembrane fluid shifts, and basically the cells pop and they die. So again, you want to have a tumor-free margin of about 1/2 to 1 centimeter. So your goal with these probes is to border the tumor, and that creates a giant ice ball. So one nice thing about cryoablation, I think, is that you can use multiple freezing stages, and you can nicely see sometimes an ice ball on CT to know that you've surrounded the tumor that you're trying to treat, and you feel good, okay, that I got it. And one nice thing also is that if you're treating a tumor with cryoablation and you see that maybe there's a little bit of a margin that's not covered, you can add an additional probe, and that'll create a larger ice ball to encompass the whole tumor. So that's one nice thing about cryoablation. So, you know, again, in general, you have to plan carefully. You have to make sure your margins are going to be okay, make sure there's no intervening structures that are nearby. You know, the tumor size is inverse to the success. 3 centimeters in general is a good number. Once you start getting above that, 4 or 5 centimeters, it can be tough to really get a good successful result. You may have to go in a second time to treat tumors. Are they close to a vessel? You know, you have to be worried about heat sink effect with some of the modalities again. What about hydrodissection? Sometimes you got to push structures out of the way. You got to get the loop of bowel out of the way. You got to get the spleen out of the way. Whatever it is, but you might have to utilize some additional maneuvers in order to kill your tumor. Sometimes you got to use air. You know, it just depends. And I'll show you some cases here that we've had to use those. There's something called high-intensity focused ultrasound, or HIFU. It causes coagulation necrosis of tumors. I have not used this before, so I don't know much about it, but it is out there to treat some tumors. So local regional therapy that we talked about is basically the the modalities utilizing the arterial flow to a tumor and trying to either cut off the blood supply or to directly treat the tumor itself without having to undergo systemic treatment for a patient's particular cancer. So what we utilize are bland embolization, chemoembolization with drug-eluting beads, and radioembolization. And you can see here a chart that has several different sizes of the particles that are utilized, with the tiniest being these small glass or resin beads with Y90 therapy. So what are our guns? What are we shooting, if you will, with these local regional therapies? So again, as an interventionalist, you come up with certain tools that you feel comfortable with, that you're used to using, you utilize them for all of your procedures, and you just feel comfortable in general utilizing them, whether it be your favorite catheter, one or two, or your favorite wire. So you got to get comfortable with figuring out what it is that you like to use. So sometimes you use a 4 French or a 5 French catheter. And again, these are just a picture of several different catheters, whether it's a sauce or an angled glide catheter. Again, 4 or 5 French, this might be a C2 catheter. So all these things are utilized sometimes based on the orientation of the vessel that you're trying to get into. And then you move into the world of microcatheters. Some of them have, just a tapered edge or a straight edge, or sometimes a funky hooked edge. So whatever it is that you need in order to get into a vessel, they have many micro wires that you can shape to help you navigate into the vessel that you want to get into. And one thing that they utilize now, and I've used it a couple times, is a Surefire catheter, which is kind of interesting because what it does is it has like an umbrella, if you will, that kind of pokes out of the end of the catheter. And what it does is it allows you to inject particles and prevent or decrease significantly the reflux of the particles. Again, your goal is to have everything forward flowing through the artery. You don't want any clogging, and this allows you to move things along in that route. So it's a cool, I guess, device that's utilized in some cases. So again, going through different modalities here, the first thing that's been around for a long time is bland embolization. We infuse embolic materials into the artery to cause basically just occlusion. So you inject non-active beads, depending on different sizes, whether it's 1 to 3 micrometers, or the 3 to 5, 5 to 7. These are used, some examples are embosines, embospheres. Bland embolization is basically what's utilized for uterine fibroid embolization. It's also used maybe for preoperative tumor ablation or embolization. If a patient has a large kidney mass and you want to decrease the amount of blood that's going to that mass, you can embolize it with bland embolization, and then the surgeon can take out that tumor shortly thereafter and hopefully decrease the amount of blood loss. So gel foam, PVA particles, these are all utilized for bland embolization. And again, this gives you good results, and you can use it to treat many different types of individual tumors. Another modality is TACE, which is chemoembolization. And chemoembolization is where you inject chemotherapy itself, whatever agent you want to use, doxorubicin or mitomycin or whatever the case may be, and you inject it into the artery itself, and then you inject an embolic agent afterwards to prevent the chemotherapy from washing out. So, and that helps to induce the ischemic effect in tumor necrosis. So again, that's utilized by some interventionalists. It takes advantage of the dual blood supply to the liver, where 75% is portal, and again 25 is basically the hepatic artery. But as we all know, that basically all the tumors that are in the liver are supplied by the hepatic arteries. So it's okay to take out the hepatic arteries, the small ones especially, because you still have much supply that's coming from the portal You just have to make sure the portal vein is going to be patent. In addition, you can inject something called Lipiodol. It's basically an oil, which I believe is from like poppy seeds or something like that. And it's injected into the hepatic artery, and it's cleared from normal hepatic parenchyma, but it accumulates in the tumor because there's an absence of these Kupffer cells. So you don't see this very often, or it's not utilized, I know, as much as it has been in the past, and it's somewhat hard to get. But one nice thing about the Lipiodol is when you inject it, it outlines the tumor that you're trying to treat. And that can come in handy because in the future, if you wanted to ablate that particular tumor, then you see exactly the margins of it. So, and people are now, like myself, whatever, if we inject Lipiodol into the tumor, then after we do a conventional TACE, then you can go back and then ablate that tumor with the modality of your choice, microwave or RFA or whatever, and you get a double whammy that's basically trying to treat that particular tumor. So again, some of the agents, doxorubicin, mitomycin, cisplatin, you kind of come up with what you like to use. In general, the patient selection, a MELD score, which we'll go through in a little bit, helps to determine how well a patient's going to do before, after, what are their comorbidities, the tumor size, the number involved. All these things have to be taken into account when you treat the patient. Contraindications would be systemic infection or extensive extrahepatic disease. You really don't want to be treating a patient with TACE if they've already walked in your door and they've got stage 4 cancer and it's all over their body. You're not going to really do them good. So you really want to kind of treat when it's fairly localized and only within the liver itself. Other things to be aware of, the portal vein invasion. It can be a factor because, again, you're taking out the arterial supply and you're relying on the venous supply from the portal vein. If you get subselective when treating the tumor, that may be okay. Encephalopathy, biliary obstruction, so you have to get certain preoperative lab values to make sure that the patient isn't overly jaundiced or coagulopathic. You got to look for AV shunting to make sure that when you treat the particular patient that it's not going to go straight into the venous supply and become more of a systemic therapy. So all those things are important. Now, one thing I like to use is something called drug-eluting beads. I think is a cool technology that we use now to treat tumors. Basically, it uses these non-reabsorbable beads, and they're loaded with a chemotherapeutic agent. And then you inject it into the tumor itself, and they lodge into the tumor. And then over time, they start to elute the chemotherapeutic agent. In general, you get a higher, more sustained dose to that particular tumor. You get less washout, and you reduce systemic exposure. So this is something I like to use, and I think in America they're called the LC beads, which we utilize here. So again, just kind of a picture where you have the blue beads, and then you mix them with some red agent such as doxorubicin, and it changes the color once you know everything's bound to red, and then you can go ahead and treat those particular tumors. So you kind of can mix the beads that have a charge on them with the doxorubicin, and it's a plus negative kind of binding, and once they're all bound, then you can go ahead and treat the patient. So it's kind of I think it's a cool thing to use to treat these patients now. So another thing that's utilized, I have not used this yet, but I know my partner has, is that drug-eluting beads that are loaded with, I run a TCAN, which is another chemotherapeutic agent. Its dose is about 100 milligrams. And in general, a protocol for treating a patient depends again on how much tumor is involved. Is it a bilobar? Is it a unilobar? And there's different protocols. There's a Japanese way of treating these tumors, based on some experience over there. But sometimes you can have you treat one side for 2 weeks, and then you treat the other side for 2 weeks, and then you go back to treat, the first side, and 2 weeks later. So you kind of can go alternating back and forth, and many times these patients in general will have to come back to be retreated because you're not effectively always killing the tumor, you're just putting it at bay, and many of these tumors still have some sort of angiogenic properties which create new vessels that you got to deal with in the future. So a little bit about the technique. You want to keep the patient hydrated. That's key. In general, we give them a gram of Ancef. Sometimes you could use some steroids to help decrease some of the inflammation. You basically do a conventional angiogram, which I'm sure many of you guys have seen before. I would typically start with an SMA run. Look for any variant anatomy. Do they have a replaced right hepatic? And then you got to carry it out to the portal venous phase, make sure it's patent, and then you can do your celiac runs and evaluate the hepatic anatomy and figure out where a good place to treat is. And use your microcatheters as you need. And again, always keep in mind to look for AV shunting because sometimes it could be subtle. Here's a case where we went in here and did an injection. You could see the tumor here, but then if you look closely, there's a little bit of shunting, so you got to be careful with treating and what it is you're going to utilize to help treat the patient. So the endpoint when doing TACE or the drug-eluting beads is you are basically blocking the arterial supply to that tumor or stuffing it up with the chemotherapeutic agent or the beads. And it's okay to kind of prune the vessels, but you don't want to necessarily take out the entire artery. So other things to look for would be subcapsular or extrahepatic lesions that might have collateral pathways, such as if the tumor is near the dome of the liver, they might have a phrenic artery supply. So all those things got to be taken into account. The next thing we'll talk about is something called radioembolization. So during my fellowship, we did a ton of radioembolization, and we used agents known as Therasphere or Sursphere, just depended on the operator and basically the day. I don't know, maybe it was the weather, but either one was utilized to help treat these patients. But one nice thing about it is you are doing kind of a radiation treatment to the tumor itself, and you get it very localized, and you can deliver very high doses of radiation to those tumors, which can cause great necrosis to those tumors and have very good results treating certain types of tumors. In general, they're either a glass microsphere or a resin microsphere, and they're loaded with this yttrium-90 agent inside them. So again, one thing that you'll encounter maybe in the world of private practice is that Y90 is only technically approved by Medicare for colorectal metastasis. So even though it is utilized, in treating many different tumors that I've done, sometimes it's hard, and this is something to keep in mind in general, is that when you're treating a particular patient, sometimes you do have to deal with a lot of bureaucracy and finding out what is approved, what's not approved in treating that particular patient. So again, when you're, I know you guys are first through fourth years, you guys will figure out who's going into interventional radiology and who's not, but there are little bits of red tape you got to deal with treating patients and which is approved by insurance and what isn't. So like I said, it's much different than just your standard diagnostic radiologist who reads x-rays and then leaves at the end of the day. So other indications for the Y90, unresectable hepatic primary or metastatic disease, liver dominant, and life expectancy for at least 3 months. Again, you don't want to treat patients that are going to pass away on you, shortly after you treat them. So you look at a lot of lab values. Contraindications are pre-treatment lung shunt. You just have to be careful. We'll talk about that a little bit. Excessive tumor burden, with limited hepatic reserve, if basically the whole liver is littered with tumors and there's no viable parenchyma, then you could treat all these tumors, but the liver itself isn't going to be able to handle it because there's not much left that's normal for the patient to even function. An elevated bilirubin, again, something you got to keep in mind. So starting a program is complicated. I helped start a program when I was in Akron, which was successful, and I know they're doing it now. But it was kind of a challenge to get it off the ground. But it's becoming more popular in some of the more peripheral hospitals, more community hospitals. So again, the radioembolization procedure itself encompasses 2 phases typically. There's a mapping phase and then there's a treatment phase. And in general, the mapping phase maps out the anatomy that you're going to be dealing with. You know, what artery is it that's actually feeding the tumor? And one of the main things we look at is are there any GI contributors that are nearby where you want to be treating? Because one of the main things you have to avoid when doing radioembolization is any backflow of these particles into any branches that would feed the GI tract, because that's known to cause ulcers. So typically what we do is we try to take out any nearby arteries that might lead to the GI tract to ensure that when we go back, you know, a week or 2 later and actually treat the patient, that we don't have to worry about there being any chance of a patient developing an ulcer. So, and in addition, during the mapping portion of the study, we inject a little bit of MAA at the desired location of the treatment itself to make sure there's no significant shunting that's going on that could cause radiation pneumonitis. So it's rare, but you got to check for that. So, and then you can use a dose calculation as how much liver you're treating, come up with a dose that you can utilize. So all those things are part of the pre-treatment. And the pre-treatment phase itself, the mapping and the embolization can take anywhere from, you know, an hour to 2 to 3 hours, just depending on the anatomy and what's in the way. So here's just a conventional angiogram that shows all of the different, you know, your typical anatomy here, and some of the arteries to avoid. You know, in most cases, you're going to take out the gastroduodenal artery. If you can find the right gastric artery and get into it, that would be another artery to take out. Again, it just depends on where you're treating. Sometimes now we're being able to avoid having to go too deep into the, or to have to embolize all these arteries, because if, let's say, the tumor is way up here and it's being fed by this branch, then you could get by with maybe not having to embolize these, because the chances of reflux all the way from up here are pretty slim, and the likelihood of causing any particles going places where you don't want them to is really low. So these are all things just to that you guys will learn about, or whoever's going into interventional radiology. So the second phase of delivery, after you do your mapping, you know, the technologist and the radiation people in the hospital will come in, and you'll set up these boxes here that have the dose on the inside, and you basically inject very slowly, once you get your microcatheter in position, the particles. You can treat the patient and then treat the patient, and then you can even use a Geiger counter to put over the patient to make sure that you got the treatment into the area of the liver that you wanted to. Sometimes you can even do a SPECT CT afterwards, which will show you where the deposition of all those radioparticles are, which is kind of a cool thing to do. So again, results for this have been shown to be very positive. And Kubi back in 2010 showed that basically the results of radioembolization and chemoembolization were basically equivalent. So complications, again, you just got to worry about this thing called post-embolic syndrome, which we'll talk about a little bit, which is fatigue, nausea, vomiting, anorexia. So you got to be aware when you're treating these patients that this can happen. Let them know you're going to have flu-like symptoms. You can have radiation-induced liver disease, which is rare but can happen. So again, you gotta monitor how much you're dosing the patient. You can get GI ulcers, which is what we're trying to prevent. So hopefully your mapping will exclude, these kind of things from happening. So one last thing before we go into individual tumors themselves is something that we occasionally do. It depends on your center. I'm not doing these too often in the community hospitals, but you might be called to do a portal vein embolization. And in general, this is kind of a interesting procedure where you embolize a portion of the liver before hepatectomy. And your goal is to cause hypertrophy of the good lobe of the liver, and by taking out and embolizing the blood flow to the bad segment of the liver, so that you get a hypertrophy and enough liver so the patient will do fine once they take out the segment of the liver that has the tumor in it. So if there's a plan for a potential large amount of liver to be removed, then this is something to be considered. Again, here's just some facts about the actual embolization and the technique, but basically you're trying to get in the portal vein and you're injecting particles or coils or whatever it takes to embolize a certain segment of the liver, and in hopes of 2-3 months down the road you'll do a CT scan and you'll look for hypertrophy of the good portion of the liver, and once you get enough liver reserve, when you do your measurements, then you can go ahead and cut out the bad portion. So now we've gone through a bunch of the modalities that are used to treat the tumors. So the next phase is to really know your enemies, but know who it is that you're trying to take out, because as we know, cancers are different. They behave differently, so different tumors have different responses. So in general, as an interventional oncologist, you're going to be dealing with several main cancers. One of them is HCC, and then you got colorectal mets, which you'll commonly see. Sometimes you'll see lung mets or even breast metastasis, which can also be treated. Neuroendocrine tumors, metastatic disease, cholangiocarcinomas, and then we get back into these ablative therapies for lung cancer and renal cancer, and then at the end you get sometimes you're called on to treat some osseous metastatic disease as an interventional oncologist. So we'll go through briefly these lesions and how we treat them. And I'll speed it up a little bit since we're cruising here. So again, HCC is the second most common cancer in the world, and surgical resection is basically the most curative treatment for these lesions. But not everybody is. Most candidates are not. Most patients that present with this are not surgical candidates. So then you got to come up with, okay, if they're not a surgical candidate, how else can we treat these guys? So we use this Milan criteria: single tumor less than 5 centimeters, 3 or less tumors no greater than 3 centimeters is basically what you want to remember for this Milan criteria and how to treat these patients. You select on the tumor size, the number of tumors, the percentage of the liver involved, and what's important is this ECOG status. How is the patient themselves? How are they functioning? So we use a chart here to go through and get an idea of how the patients are. And ideally your patient's going to be a 0 or a 1 when treating these patients. 2 you could treat as well, but anything kind of 3 or below, you might want to look more into the palliative type of treatment. Other things we use is this Child-Pugh score to get an idea of the overall extent of the patient and how they're doing, to kind of put it into some sort of quantitative fashion. Again, cirrhotic patients in whom resection is planned, but it's a large tumor and you need some functional reserve, you might consider the portal vein embolization. So we also use this Barcelona clinic liver cancer staging, kind of a map here to give you just a brief idea of where the patient is on this child's Pew score, and what might be the best modality to treat that particular patient. So you just look at your patient, come up with the numbers, and look, and this will give you a rough idea of what might be the best way to treat that patient. Sometimes the patient, let's say, is an 85-year-old male with a single tumor that's 2 to 3 centimeters, but even with microwave ablation during its infancy, showed fairly high 1, 2, 3 year survival rates for HCC that was treated with percutaneous microwave ablation. So again, you can get good results with these with some of the thermal ablation. Again, embolization, the local regional therapy, you can even downstage sometimes the patients into being a transplant candidate after they've been treated. One thing I just want to point out to you guys is that we deal a lot with this post-embolization syndrome, where the patient's going to be in a lot of pain because you are cutting off a fairly decent supply to the liver, and they're going to be in pain. So I like to start my patients with a PCP pump, usually with Dilaudid, and start it actually in the IR room, and then see how they do overnight. Again, you want to just monitor them. You got to be cognizant of an abscess that could develop, so you do want to do some CTs shortly thereafter, make sure there's been no complications. So other data that you might be interested in is that, again, the radioembolization can be well utilized and tolerated for HCC, and you get lower liver toxicity even sometimes with the radioembolization. So another agent that's utilized is sorafenib, which you'll hear somewhat in the literature and is definitely spoken about by medical oncologists, that has been shown to have increased survival and prolongation for survivals in the 3 to 5 month range. So again, we're not always really curing these patients as much as we're trying to give them a few more months of sustainable life in this world. So follow-up is MRI every 3 to 6 months or so. So here's a case where patient has a HCC here, which was treated with Debtase. Again, you can see via the angiogram this large tumor. This is at a 1 month follow-up, a large area of necrosis for the tumor, and then about 18 months later, most of the tumor's gone. So colorectal cancer metastasis, again, it's very common, second leading cause of cancer death. Patients typically present already at stage 4, 50%, that's a lot. 5-year survival for RF ablation of non-surgical candidates are similar, but less than that of surgery if it's a 4 centimeter or smaller lesion. So first line is the chemotherapy, is what they typically use, but right now Y90 is a category 3 recommendation, which we said, so it's more of a salvage type thing, but it can prolong the patient's life and overall progression, or curb the progression of the tumors. So other things, since none of you guys are going to remember any of these details in terms of the overall results, but there is some level 1 evidence out there with treating colorectal mets with the use of Y90 and the following, in certain scenarios. Level 2 evidence is out there as well, and it's got a fairly good safety profile out there. So in general, there's a level 1A evidence out there for chemomolecular treatment as well as with transarterial therapy. So you get to have a discussion with the patient as to what they would like to go through. Do they want systemic chemo, or do they want to try the transarterial route for treating the patient? So here's a case that we did last year. Young female, she came in, she had multiple metastatic lesions throughout her liver, and we decided to do Y90 therapy on her. So again, you get your planning angiogram, you look for which arteries you need to take out. So we took out a left hepatic artery, take out the gastroduodenal. If you can get into the right gastric, try and take that one out as well. Then you do your lung shunt fraction in this patient, which was fine, and then you bring the patient back a little bit later and do the actual treatment 2 weeks later. So she underwent treatment here, utilizing your microcatheter. So 2 months after treatment, in this lady, you could see that a lot of these tumors have undergone necrosis and have very little viability left. And then she followed up with a PET scan, and all those tumors that you think would be hot are not hot anymore. But there was a segment near the dome, which again we talked about earlier, which can be a hard area to treat, that she did have some extra hepatic tumor supply. But again, here's a PET scan. All those tumors which you think would be hot are now cold, but she did again have a little bit of residual tumor here. She ultimately went on to have resection of that area. So neuroendocrine mets, carcinoid, pancreatic. I've treated a few of these patients, with these lesions. So you just got to know what it is that they come in with. Bland embolization, chemoembolization, they all can be utilized to help treat these patients. Even radioembolization has been reported to provide a complete response in even as much as 18% of the patients, but no overall survival. So cholangiocarcinoma, another, it's not a common tumor, but they do show up. It's kind of rare, again. You can use Y90 chemoembolization, whichever one is approved basically by the insurance. So here's a patient, like I said, I was hoping to treat this patient with Y90, but it wasn't approved by the insurance. So we went ahead and treated this patient with drug-eluting beads. Here's his MRI where he's got up to motion artifact, but you can see this large heterogeneously enhancing tumor. I went ahead and biopsied this lesion because, again, we weren't sure if it was HCC or cholangio. It came out to be a cholangio. We did I did my initial angiogram here, and you could see that the patient had a replaced right hepatic artery. So once we get into this artery, you could see some of the tumor blushing, and then you go ahead and treat here through a microcatheter, causing some of the pruning of the vessels. And then we went ahead and treated the left side kind of in a similar fashion, microcatheter, embolization. So, and that guy again had the post-embolic syndrome. I had to give him pain meds and all that stuff. So, but you can see here on a follow-up MRI that we get a lot of tumor necrosis, and the patient ultimately has been doing well. He's not cured from his disease, but we've definitely kept some of these tumors at bay. Could this patient come in and have another treatment with drug-eluting beads? Sure, no doubt about it, but he does have some more extra hepatic metastasis now, so the oncologist wasn't wanting me to do too much, and I don't think he wanted too much more. So again, going through our last couple of tumors that we try to fight, our lung cancer, we know is really common. There's 4 stages. The selection of the patient, it's typically, again, patients that can't have surgery, because if the patient has a solitary pulmonary nodule and they are operable, then ultimately the patient should go to the operating table and just have that cancer taken out, because that could be curative. So, you just got to look to see where the tumor is itself, how many there are, how big is the lesion, as to what the modality is best utilized. So we like to use general anesthesia when doing this to help control the patient's breathing. We perform it under CT guidance, as I'm sure everybody does. Again, the treatment time, we typically use RFA here. It's common for a patient to get a pneumothorax because you're putting in a larger lesion. One thing I will tell you is that last year my partner and I presented a paper at SIR that talked about us doing when a patient comes in, let's say it's a 79, 80-year-old female or male, whatever, that has a solitary tumor and it hasn't been diagnosed yet, then go ahead and actually do the biopsy, but at the same time, since we know it's going to be most likely a malignancy if it's increasing in size, is go ahead and treat it in one session. So now we're trying to actually do both, where we biopsy and treat in the same day for these lesions. Results, again, are very favorable for these lesions. So I'll just show you another case example here where we treated this tumor. It's kind of an infrahilar. You could get, a little bit of a heat sink effect from the adjacent vessel, but overall the patient did well. Here's another tumor. This is what it looked like initially, and then about 3 months later, it's significantly increased in size. So again, this is a tumor where you just biopsy it and treat it in the same session. So we went ahead and RFA'd it, and then several months later, I believe this was 3 months later, you can see that most of the time the tumors get a little bit bigger, and then later they'll get smaller in size. Or this is 2 months afterwards. So, and then a common tumor that we also treat is a renal cell carcinoma. Again, 4 stages, which I'm sure you all know, that you can use RFA, cryo, microwave ablation. I like to use general anesthesia. Typically, tumors that are less than 4 centimeters, where they're located makes a big difference. The more central the tumor is to the renal pelvis, the harder it is to treat, and or maybe you shouldn't treat it because you don't want to be dealing with freezing and burning central vessels or the collecting system, because that could cause a permanent hydronephrosis, that kind of thing. So, sometimes I do these as an outpatient if we start early enough in the morning. Cryoablation has great initial success with treating most of the tumors that fit the criteria pattern. And again, you just follow up with a CT 3, 6, 12 months looking for an enhancement. Again, it's just operator preference whether like RF or cryo. So I think cryo is better. Anyway, here's a case that we had recently. You can see here this tumor. It's about 3 centimeters or so, maybe 3.5 centimeters along the mid to upper aspect of the kidney. But what's unique and what you have to keep in mind again is how you're going to border this thing. What's going to be adjacent to your probe. So first thing is we put this patient right side down, and you can see that the lung's in the way. So now you got to come up with, okay, how are we going to treat this tumor, because you're not going to want to go through lung in order to treat it, and you can't go through the spleen in order to treat it. So we decided to put this guy prone, and we had a small window to get through, and we decided to make, or I decided whatever, to make a diamond-shaped treatment ball around this tumor. So we put I put one probe on top, I put probes along the side of it, and then I put one underneath it for treatment. And at the same time, I went ahead and biopsied the lesion to prove that it was a renal cell, which it was. And if you see here on this particular picture, you can see one of the probes is very close to a loop of bowel, and you have to be very careful with getting bowel out of the way when you do these treatments. So one way to do that is to do something called hydrodissection, which is utilizing saline to push the bowel out of the way. So I took a needle and tried to put it in this little groove here and start to push away the bowel by injecting a ton of saline. And ultimately that worked because the loop of bowel is now out of the way, and then we went ahead and freeze this particular tumor. So anyway, osseous metastatic disease is another thing that you treat. Again, you can RF ablate it. Around the pelvis is a great place to treat because patients are uncomfortable. They can't sit down. Sometimes you can treat spinal lesions. You can add some cement as needed. So in general, those of you that are going to go into interventional, communication is key because you're basically now a doctor, and as I'm sure a lot of you guys know, interventional radiology is going to have its own special, own pathway right out of medical school, because your mindset as an interventionalist is different than that of your standard diagnostic radiologist. So you learn how to read these things, but you got to know how to talk to the patients. Sometimes you got to, sell things to the patient to get them to understand exactly what it is that they're dealing with, and what the best modality is to treat, which is why you got to be able to, criticize and really understand the literature that you're dealing with. So you got to have some people skills, and setting up a clinic is great if you could see patients, in the office beforehand, do your consult, and then follow up with them is important. All right, so for the last couple seconds, I just wanted to show you guys a couple other treatment modalities. This is where I was going to have you guys just type in, if anybody wants to type in, what modality you think would be a good one to treat this particular lesion. That would be cool. Not sure how that works, but so if anybody wants to just walk up to the computer and type in what they think would be a good way to treat, that would be great, if anybody's still there. So I'll give it a second. Carol, you still there?
Yes, this is Mary. I'm still here.
Or Mary? Would they be? How would I know that anybody's answered this thing? Would it show up an answer somewhere?
It'll show up in the questions box. I think you just had one pop up.
All right, cool. So there you go. Chemoembolization. Sounds like a good one. Okay, perfect. I don't know how to make this bigger, that little box. It's like a tiny little answer box. Something that treats greater than 3 centimeters, correct. So with a low heat sink. Yeah, so this guy, you're not going to want to be using any of the thermal ablation. These tumors are too big and there's too many of them. So chemoembolization, drug-eluting bead, or radioembolization would probably be good. But what's the first thing you got to do? I'd probably do a biopsy of this, just to see what it is and document it. All right, so only 2 more left. So how about this one? What do you guys think would be a good way to treat it? So let's say there's 56, and we're going to say this patient has no comorbidities. What would you think would be a good way to treat this? What would be the best way to treat this? Solitary lung nodule, no metastatic disease, no comorbidities. What would be the best way to treat this patient? All right, but for the sake of time, okay, someone wrote ablation. Okay, so ablation would be a good one, but I think the best answer, the best thing that you could do for this patient would be actually to send them to surgery. So hopefully the oncologist would know that, but a solitary nodule in a patient that's this young with no comorbidities, curative-wise, this patient should go to surgery. If this patient was 80 and didn't want to have surgery and all this other stuff, ablation, RFA, definitely. Let's do it. Sign them up. Do the biopsy and the ablation at the same time. All right, so last one is, let's say this patient, new renal mass. How are we going to treat this guy? Yeah, we can do some sort of thermal ablation on him. Microwave, this is a great case to treat. I wish they all look like this, but they don't. So sometimes you get cases that kind of look like this, and your urologist is calling you, and he's like, hey man, can you do anything for this patient, because I don't know what to do, or take out both of their kidneys. So, you just got to have a conversation. This tumor over here, you could potentially treat. One thing, I've done is actually gone in and embolized this tumor that's fairly big with ethanol into the artery itself, and then go back and actually do a chemoembolization, or a thermal ablation, like a cryoablation. So it shrinks the tumor to get it into a decent size and then go back and treat. This tumor is pretty much too big, so your best option would probably be, again, to probably just embolize this segment of the kidney, and maybe the surgeon would take it out. So anyway, here are my references for the day, and again, thank you guys for listening, and happy Veterans Day, and thank all the veterans out there for their support for this country. So if you have any questions, I guess you guys could email me, but thank you much.
Thank you very much, Dr. Isaacs, and thank you everyone for attending and hanging on there at the end. This is the last lecture for this year, and we'll see you guys again in January. Thank you again.
All right, thank you again.